Thank you, Philip, for your kind introduction. So my topic is on interventional EUS from practical to extreme. So I'll be going through various developments on EUS interventional procedures. So these are my disclosures. So in the past few years, in fact, we have seen a very quick development in different kinds of EUS-guided drainage procedures. In fact, I would describe it as a festival because almost every year or every few months, there will be a new procedure that is being described. So nowadays, we can perform easily bowel duct drainages. And after bowel duct drainages, the stent can be used as a portal to allow the scope to go into the bowel ducts as well. Gallbladder drainage, we are doing a lot of studies on gallbladder drainage. Again, after gallbladder drainage, the gallbladder is now in the territory of an endoscopist. So it has markedly increased the ability of the endoscopist to go to another previously inaccessible organ. And moving forwards, nowadays we can even perform EUS-guided drainage of the GI tract. So for example, in a patient with aphid limb obstruction, we can perform aphid limb drainage. And also we can perform a gastrojejunostomy as well. 2 years ago, we've published this consensus guideline on the optimal management of interventional EUS procedures from the So this is the first guideline published by any endoscopic society on interventional EUS. And we have gone through a very rigorous approach in terms of setting up the guidelines. I've spent almost 5 years in various stages of this guideline. And in this guideline, we focus mainly on 4 procedures, including pseudocyst drainage, biliary drainage, pancreatic drainage, and also celiac plexus ablation. And the guidelines not only cover the procedure, but we also cover indication, pre-procedural planning, post-procedural planning, and also training. So if any of you are interested, please take a look. We also plan to have an update on these guidelines soon. We plan to include more procedures like gallbladder drainage, wall of necrosis, or even GJ. So pivotal to the development of all these EUS drainage procedures is the development of EUS-specific stents. So I think some of you may have heard a very famous stent called a Axios. This can be classified as a dumbbell type of stent. These dumbbell types of stent, you can see, have a characteristic shape where both ends of the flanges look like a dumbbell. So the flanges are much larger in diameter. It also serves to prevent migration of the stent. The other thing is the stent lumen is usually quite big. So Axios is now up to 20 millimeters. Spexis is 16 and Nagi is around 10. So with these type of stents, not only it makes the anastomosis more secure, also the delivery system is also now, many of them are cautery enhanced, which allows a single-stepped placement of these stents. Tubeless type of stents is also available for EUS drainage. These are mainly used for HGS or CDS. You can see these stents have a characteristic partially covered design. So this part is uncovered, which allows the stent to anchor onto the liver, into the bile duct, and the cover side is to bridge between the liver, the bile duct, and the duodenum. There are even more many newer devices coming out. For example, this is a steerable needle, which is coming out from Medtronic, which allows the endoscopist to change the direction by turning the needle around, so which helps to guide the direction of the guide wire. These are the cautery enhanced delivery system. This is a hot Spexis, which has come out as well. This is a Axios hepatical gastrostomy or CDS stent. You can see the trademark Axios dumbbell on one side, and the other side is a covered to uncovered metal stent, again designed for use in HGS or CDS. So the development of these EA-specific devices are very important because it allows performance of novel procedures and reduces the difficulty of the procedure, and also reduces the risk of leak or complications. It also helps to shorten the procedural time as well as decrease the learning curve for the procedure. In terms of interventional EUS, current indications, PFC, I think now endoscopic drainage is the standard, which includes both pseudocysts as well as water necrosis. For BD drainage is mainly indicated in patients with ERCP. Gallbladder drainage is indicated in patients with at very high risk for cholecystectomy. PE drainage in patients with a PD or PJ stenosis. Celiac plexus intervention mainly for patients with intractable tumor pain secondary to celiac plexus infiltration by tumor. Of course, these procedures can be developed more in the future, and many new procedures can also be considered. In biliary drainage, there's a lot of studies that has been done, and some are still ongoing, which are looking at the potential of EUS-BD drainage to maybe replace ERCP or become the primary method of drainage. For gallbladder drainage, we know that I performed a study randomized control trial comparing EUS versus percutaneous. So EUS has a lot of advantages. For PD, it may replace enteroscopy or surgery. For gastroenterostomy, it can be an alternative standing. And tumor ablation may help in terms of cysts and tumor control. And also a very interesting subdivision of endoscopy is the endohepatology. So now we also have the ability or devices which allows us to assess the degree of cirrhosis, mainly by measuring the portal venous pressure gradient. So for PFC drainage, I think this is becoming or has become standard in many centers. So I'm not going to go through too much of the background. I think there are a number of issues that still needs to be resolved. Firstly, whether the newly available metal stent actually provides additional advantages over plastic stent, whether the role of PPI versus H2O2 or H2O2 in terms of reducing the need of necrosectomy. After drainage, what is the timing for necrosectomy, and also some newer device which is not really designed for EUS but is related are devices for necrosectomy. So this device is called the EndoRotor. It was previously designed for mucosectomy. So you can see the tip of this device is a rotatable device. So now they are using this device to perform necrosectomy. You can see all this black gluey stuff is necrotic pancreas. The tip of the device, you can see it's a kind of like a cutting blade, cutting rotor, which cuts around continuously, and inside the lumen, suction can be applied so as to suck out all the necrotic debris. So I've seen a few cases. It seems to be quite effective. Of course, you need to be careful not to suck in any vessels or anything like that. But it seems for those who have done necrosectomy, you know that sometimes the procedure can be very cumbersome. So it seems like the device works very well in these sort of cases. In terms of EUS-BD drainage, I mentioned a very hot topic right now is whether EUS-BD can potentially replace ERCP. So the main rationale is that in EUS-BD, the stent is placed away from the tumor, so this may potentially reduce the need for reintervention or reduce the risk of tumor ingrowth. So there may be prolonged stent patency, reduced procedural time, and there's no risk of pancreatitis. Of course, to perform EUS-BD, you need a technical expertise. There's a risk of complications, as well as the need of dedicated devices, which may make the procedure more expensive. So this is a patient with a hepatogastrostomy. This is being the EUS is placed in the stomach. You can see a dilated left intrahepatic duct. So puncture first with a 19 gauge needle. You can see the patient previously had a duodenal stent. That's why they cannot perform ERCP. After puncture with the needle, a guide wire is passed down. And then we exchange to the device. So this device is a single step device, what we call a single step device. So you can see the delivery system in the tip. There is a sort of a dilator. So meaning I do not need to dilate the tract before placement of a stent. So normally we would need to dilate the tract with cystotome followed by a 4mm balloon. So there are at least 2 or 3 device exchanges required. And during device exchange, there is always a risk of complications or bowel leak. So by using this device after puncture, we can immediately change to this dilating delivery system. And you can see the device with a gentle push. It goes in quite smoothly. And then following the guide wire going down. And then we'll open the stent radiologically in the X-ray guidance. So half of the stent is open under X-ray guidance, and the other half of the stent is actually open inside the endoscope. So we believe this way is the safest way to deploy an HGS stent. So after the stent is deployed inside the channel, we will slowly push it out from here. Push it out, stent out a little bit, pull back the scope, push out a little bit, pull back the scope until the entire stent is being pushed out from the channel. So this study published by Asan Medical Center involving 4 tertiary centers in Korea comparing primary EUS-BD versus ERCP. They showed that the technical success is similar, but the overall adverse event is significantly less in the EUS-BD group. Reintervention rate is 15% versus 42%, and the stent patency was 63% versus 36%. In the EUS-BD arm, obviously there were no patients with pancreatitis, and in the ERCP arm there was 14.8%. So this study is promoting EUS-BD as a primary method of draining the bile duct in patients with unresectable tumor. So this is the Kaplan-Meier curve showing that the EUS-BD arm has a significantly longer stent patency as compared to ERCP. My main complaint is that seems that the stent patency in the ERCP arm is a bit low for this study. So we are now performing a randomized trial, multi-center study. We're up to around 140 patients recruited already. So hopefully we can also try to answer this question as well very soon. So as I mentioned, EUS drainage procedures is a way to drain the system, but it's also a way to access the system. So this patient actually had a post-Whipple complete hepatotracheostomy stenosis. A PTBD was inserted. We first converted to internal drainage with HGS because the patient really didn't want the PTBD. And then afterwards, we used the hepatogastrostomy as a means of accessing the bile duct. So I used a ultra-thin nasal endoscope, go inside the bile duct. And once I was inside the bile duct, then I tried to look for the anastomosis, which you can see is actually completely stenosed. So I tried to insert a guide wire, but it wouldn't go in. So afterwards, I had to use a needle because I can see from air cholangiogram the jejunum is very closed. So I tried to puncture the anastomosis and try to get into the duodenum. And eventually I was able to see contrast in the jejunum right there. So afterwards I was happy. And then I inserted a 018 guide wire inside the jejunum. Followed by dilation of the tract with the cystotom. So you can see some sutures from the previous hepatojejunostomy. And eventually the cystotom went in, and then I dilated the tract and then placed one double pigtail plastic stent. So eventually, after a few sessions, the patient was dilated to around 8 millimeters. I placed 3 double plastic stents, and the patient after a year was stent free. For gallbladder drainage, again, this procedure is becoming more and more popular, mainly indicated for patients with acute cholecystitis. So this is one of the hot system, in which the tip has a cautery tip, and then again allowing the direct puncture and opening of the stent at the same time. So US gallbladder drainage, as mentioned in the Tokyo guidelines, is one of the alternative to PDBD, PTGBD in patients at very high risk of for cholecystectomy. So mainly in institutes where there are high volume institutes that can be performed by skilled endoscopists. We have published a meta-analysis in endoscopy comparing EUS-BD versus percutaneous cholecystostomy, 5 comparative studies, 495 patients. Technical success rate and clinical success rate were similar. Total adverse events rate were less with EGBD. Hospital stay was less, shortened in EUS-BD. Recurrent hospital admissions reduced, recurrent re-interventions was also less in US gallbladder drainage. So this is expected because with percutaneous drains, the patient often come back with a blocked tube, dislodged tube, all sort of problems. And also patients in general do not like these external tubes. We have also recently published the results from this randomized trial, DRAG study, comparing US versus percutaneous cholecystostomy. So in the US arm, we showed that the 1-year adverse events rate was significantly less, 25% versus 77%. Recurrent cholecystitis was also less, 2.6% versus 20%. Reintervention, again, less in US-BD. Unplanned admissions, and also 30-day adverse events were all in favor to US gallbladder drainage. So right now in management of acute cholecystitis, I think for surgical candidates is of course laparoscopic cholecystectomy. Marginal candidates, according to the chocolate trial, is again laparoscopic cholecystectomy in patients which have multiple comorbidities, which you don't plan to perform cholecystectomy. I think with the DRAG study, we can conclude that EUS-BD is the treatment of choice. Again, after gallbladder drainage, the stent actually allows us to act as a portal for us to enter into the gallbladder. So a new procedure known as Peroral Cholecystoscopy has been invented. So we have published the results of Peroral Cholecystoscopy. In 25 patients, 29 cholecystoscopy, we could perform all sorts of interesting stuff like MBI, confocal, EUS, or even endocytoscopy. The overall stone clearance rate in after cholecystoscopy is 88%, and these are just some images from the cholecystoscopy. You can see a sort of multiple papillary projections inside the gallbladder. This is a patient with a necrotic gallbladder. I think the patient has suffered from a very severe cholecystitis. So you can see a lot of necrosis inside the gallbladder. This is interesting. This is a patient, elderly patient, which pre-drainage CT didn't see anything. But when we went inside, we see a incidental cancer of the gallbladder. So it was an elderly patient, so surgery wasn't planned anyways. But again, this is a very unusual site. This is a patient with a stone, big stone in the gallbladder. It's so tough that it broke 2 of my BML. So eventually I had to use a laser lithotripsy to break it down. So these are very interesting adventures inside the gallbladder, and this is now possible. In terms of EUS gastroenterostomy, now we can perform a EUS guided GD. It's not a GJ because we're usually puncturing or draining the 3rd, 4th part of the duodenum. So thanks to this device, it's called a double balloon occluder. There are 2 balloons in the device, and water can be filled in between to allow performance of a gastroduodenostomy. This is the configuration is of course very different from our usual surgical GJ. This is an interesting patient. You can see right here, all the small bowel is actually on the right side of the patient. So it's an undiagnosed malrotation, and the patient had a gastric outlet obstruction. So before the procedure, I was doubting whether gastroenterostomy was possible. So, but with the double balloon device, I was able to distend the small bowel. So the first part is still to cannulate the stricture. And then I will remove my scope. And then I would insert a double balloon occluder. This is the tip of the device being pushed in. The tumor is here. You can see some resistance. The first mark is the mark of the first balloon. And this is the second mark of the second balloon. So the 2 balloons would be inflated. And then a segment of bowel in between the 2 balloons could be distended and filled with water. So 1 balloon here and the other balloon here. The tumor is around here. So this is 1 balloon and the other one here. So after inflation, it would occlude this segment of small bowel. And then we can inject water in between the 2 balloons. You can see a very distended small bowel right there. So it's kind of like a drainage of a pseudocyst or a gallbladder. So you can just go in direct puncture, burn the way through, go inside, and then deploy the axios. And the gastroduodenostomy would be finished in 5 minutes. Okay, distal flange open, and then we oppose the 2 lumens by pulling on the axios, followed by deployment of the proximal flange. So EUS guided gastroenterostomy, we will perform a randomized trial on comparing a EUS guided GD versus duodenal stent, and again, hopefully you can show the benefits of this procedure. As mentioned previously, now there's a new subdivision of endoscopy known as endohepatology. So for US, we can also perform variceal surveillance, EUS guided liver biopsy, portal vein sampling, and also measurement of portal pressure gradient. So this study was published by Ken Chan, showing that by puncturing the portal vein, we can measure the portal venous pressure. So By puncturing the portal vein, usually we would perform it in a transhepatic manner. So the needle will first go through the liver parenchyma and then enter in the portal vein. So the risk of bleeding is minimal. In terms of radiofrequency ablation, nowadays this is a very hot topic, but this is not the only device which we can use perform a EUS-guided ablation. We can use alcohol, we can use high flu, and also most recently, an interesting substance known as OncoSeal. It's a liquid radiotherapy. So it can be up to 100 grays, can be delivered with the injection of this liquid. So this is a patient with unresectable pancreatic cancer. We have a protocol to evaluate the use of efficacy of radiofrequency ablation. This is a tumor. The needle will come in from here. So this is a pre-procedural contrast imaging. We want to see the viability of the tissues in the tumor. And then the needle will be inserted. There is a needle. And during radiofrequency ablation, you will see some bubbles coming up right there. So the needle is a needle with a water coolant in the tip. And it can be used to cause a temperature, raise in temperature to 60 degrees for ablation. So multiple ablations can be performed along the track of a needle. And then if we need, we can repeat the ablation around the tumor as well. Of course, the risk of this procedure, most worrisome risk is pancreatitis. Somehow for pancreatic cancer, I think the risk is lower because these patients already have a tumor right there, and also the PD is obstructed very early on in the disease. So again, studies are ongoing, comparing the use of, assessing the efficacy of RFA. So hopefully we will know the results very soon. So in terms of the future of interventional EUS, many new procedures coming out, including GJ, tumor ablation, and portal venous interventions. So I think we are entering a period of boom for interventional EUS. There are many exciting new opportunities, but of course we need more data from randomized trial required to confirm the efficacy. So thank you for your attention.
Thank you very much, Anthony.